start off with our first speaker, which is Eddie. And Eddie's going to talk about cardiogenic shock cellular pathways. Good luck.
Oh boy. So excited to be doing this again this year. And Phyllis, it's great to do this with you. I told Phyllis you just take over. So, 7 minutes. Nice to be here. Samuel Gross talked about shock, and this is what he said. He was one of the fathers of surgery. He said, a manifestation of the root unhinging of the machinery of life. Unhinging, in my opinion, is dysregulation. I know, that's nerdy. Machinery of life, we're talking about cellular molecular pathways. And what I'm going to focus on, if you just do an F2 on your EPIC, I'm just joking, you'll go to the star. We're going to talk about catecholamine bombardment and desensitization and downregulation of receptors, particularly adrenergic. We're going to talk about inducible nitric oxide and how that pathway was tried to be modulated in the TRIUMPH trial, but it failed. And we're going to talk about a new paradigm just real briefly, real quickly. You guys know I'm a big fan of ketones. Ketones appear to be vasodilatory. I think the evidence is getting stronger for that. So it's maybe a target potentially in the SIRS phase of shock. So if we start with this, we know that the adrenergic pathways in the vasculature, including the smooth muscle and the endothelium, have second messengers. And these second messengers are what really are the biological basis for vasodilatation. And these second messengers are regulated by pathways that are very interwoven. Here I'm just demonstrating alpha and beta adrenergic receptor activation through the different second messenger systems. But basically in a very, simplified way, what I want to really focus on is the recent data that there is receptor downregulation early in shock. So we know this in heart failure. We know that there's beta receptor downregulation in chronic heart failure that makes patients less beta adrenergic responsive. What I didn't know before I started looking at this talk is that there's receptor downregulation in the acute phase of shock. The data is very, very strong. So think of it as a bombardment of a system that's overwhelmed. And there's evidence for downregulation in the angiotensin II, the AT1 receptor, and I'll be talking about that briefly. There's also receptor desensitization. So here's the data, and again, many other studies that basically show, this is an animal model in which they're using a polycytokine, especially a secoligation model, polycytokine, aggravated shock. And what they show is that in the midst of several cytokines, you actually downregulate the angiotensin II receptor. And that's shown in the first. And the consequence of that is that you do not have the ability to vasoconstrict through the calcium-induced transient from angiotensin II. And here is here's an associated protein called the angiotensin type 1 receptor associated protein. There's a knockout. This actually helps traffic in the cell, the angiotensin II receptor, so that it's easily accessible as a receptor for angiotensin II. So the AT1 receptor gets trafficked by this, so you're sensitizing, and if you knock it out, you basically, through an endotoxemia model, you can reproduce so-called, vasodilatory or refractory vasodilatation. So, more and more we think about this later phase of shock in cardiogenic shock of when it starts. When does someone get SIRSy? Oh, it's when the catecholamines start to be required more, when you need more pressors. I think it's way earlier, and we just don't have the ability to detect it. It makes sense, right? I mean, there's a counter. It's an injury of cells, but it's probably more than that we don't understand. But one of the important players is inducible nitric oxide. And through inducible nitric oxide, so nitric oxide synthetase is the catalyst for molecular oxygen to be transformed to nitric oxide. And one of the targets that was recently used was, so here's the pathway here. You actually have vasodilatation through nitric oxide, through calcium channel induced calcium transient, and then you get a vasodilatory state. Basically, the balance of whether you block nitric oxide or not, it's not that straightforward. I remember being a junior attending at UCSF and saying, let's give methylene blue early. Well, let's not until we study it. I mean, that may have been a bit premature because we saw so much of the MCS-induced shock. But there's a balance. There's some downside to it. So in the TRIUMPH trial, what they actually did is they used a L-arginine analog, Til-arginine, to block. And what they did is they gave this to patients in post-MI, early cardiogenic shock. There was some signal, not significant, that maybe there were less time under the shock domain. And there was some signal that your blood pressure may have been a little more robust. And all of that was expected. The problem is, it didn't change mortality. And I think of shock trials like this. It's my first cartoon I've ever put on as a speaker, by the way. I hope somebody laughs. I'm just joking. I'm going to tell you, I feel like you can also have a surgeon with a scalpel that is totally blunt trying to do a dissection. I think that's the problem with shock trials. What target you use, a lot of times is based on a lot of bias. So switching to ketones really quick, we actually know that acetyl-CoA is a common currency, acetyl-CoA of fuel, and you get glucose and fatty acids. Recently, through some work that we ended up doing at Penn with Ken Margulies, we found that the failing heart is reprogrammed to utilize ketones. And this was a very special identification when we were doing lipidomic analysis. We then began to think that ketone bodies have a whole range of molar concentration, unlike the other substrates. And so some scientists and some clinicians, investigators, like the team at Aarhus in Denmark, they said, well, why don't we give ketones and see if we can improve, let's say, for example, the preservation of the transplanted heart. So I just want to show this model very quickly. That's our work that I'm going to skip through. And I'm going to show this model. This goes back to the perfusion model that was done by Dr. Tagmeyer in the past. He found that ketones were an avid substrate for the heart. And basically what this pig model showed of NRP-DCD is you give beta-hydroxybutyrate up front, you then go on, and you actually show improvement in the heart at the time of NRP. But guess what happens when you give beta-hydroxybutyrate again towards the end? You show improvement of the heart. You also show a vasodilatory effect. When you give it again, every pig dies of refractory vasoplegia. So that's just for the audience, maybe for some scientists here, look into maybe a pathway by which our own ketosis, when we're stressed, we induce ketones. Look into maybe how humans may actually be not well off when there's a ketotic state in shock. Thank you.
Thank you, Eddie. Questions or comments from the panel? Yes.
Great talk.
Thank you, buddy.
I guess it's on, yeah.
You're on.
Going back to that arginine study, what is the endpoint of mortality? Is that a real, we have to goes back to what the theme of the discussion has been for the last day. Is that the endpoint for every therapy in shock? Should it be mortality be the endpoint in a therapy like that? Like question, with blood pressure stabilization, because obviously there's other targets being involved. So
Yeah.
would that be, should we just be calling it as a failure of strategy?
Why don't I ask the panel a little bit, since I'm supposed to moderating as well, ask the panel, what do you guys think of that Triumph trial was actually 160 in each arm, and the endpoint was mortality. There was a signal that you may be less in a state of shock, hours during shock. P-value was 0.16. I'll answer just in my opinion, because of how hard it is to know if you're benefiting or hurting a patient by blocking nitric oxide, I'd want to see something strong like mortality or some strong morbidity endpoint. I wouldn't want to just see something that's hours under shock, But what do I?
Naveen and then Dr. Carr.
Yeah, first of all, really great talk. I always enjoy this. Going back one step more basic. One of the challenges I think with things like targeting NO is when you target something that's ubiquitous and basically has multiple pleiotropic effects, it's really difficult to control it. Especially if you're giving something systemically, you're not giving it regionally. So I think really part of this requires a multi-pronged approach. You heard the point about needing more biomarkers, more biospecimens. This is critically important for precision medicine in cardiogenic shock. It's a huge lift to do that. We've thought about it. It's very expensive, very difficult, and multiple time points, et cetera. But I think to the point about L-arginine and even other things like non-selective targeting of TGF-beta, which we know that story very well, it's very difficult when you go after something so ubiquitous and pleiotropic. Having said that, if you go after something that has a targeted effect that's mechanistically in line with one of the primary drivers of mortality, cardiac function or even systemic blood pressure, et cetera, but it's targeted. And that's the tricky part with the drug component. So I would say the L-arginine concept makes sense. Patient selection, how do you identify the companion diagnostic that tells you that that SVR of 2,000 is your target? That patient, if you stratify those cohorts, really get to the sweet spot, you might be able to do it. But I think we still need more discovery science to identify the optimal target.
That's Richard.
See, vasodilation as a target, it's the final common denominator, because at the end, everything leads to vasodilation. But the activation, the three cardinal, at least as we understand now, is the ATP-activated potassium channels, number one, and number two, deficiency of vasopressin, and number three is the inducible nitric oxide, which you're targeting. So instead of targeting the final common pathway, is there any way to go a little more upstream and prevent these three things so that we don't have vasodilatation?
I was trying to allude to that really briefly, Biswajit, with that slide. As we know, Dr. Hotchman has the slide where you see the inducible NOS and the surge coming later. Maybe it's coming right at the moment of an infarct, or it's coming at the moment of an infarct with somebody getting, altered, right? There's a total neuropathology there. There's a neurobiology of iNOS induction in the brain as well. I think it's a great idea, is to see if you can target, figure out if someone's getting vasodilated. Are they making less urine early on and all that stuff? And you may want to either, I don't know what the answer is, what you do next.
So there's actually data that'll be coming out soon that shows, like if you look at cytokines that are in the circulation, the inflammation, especially if they're in patients that have had, heart failure. I think if you start with the heart failure patients that end up in cardiogenic shock, they're already inflamed. And there is a certain collection of cytokines that are circulating that predisposes them to another insult that then makes it worse. This is happening days to weeks before. It's different when you have an acute MI, that's a different inset, right? But the gradual decline that's happening in 2/3 of our cardiogenic shock patients is something that's happening well before they present to hospital. And that's what we have to really figure out. So, and I actually would challenge you, Naveen, it's not as expensive if you think to actually collect biospecimens. I run our biobank, and there's ways to do it. Happy to talk.
Phyllis, is that in Canada?
Yes,
Can we
but
send you?
I'm willing to come down to the U.S. for a fee. We'll move on. Thank you so much.